Good morning. It's 7:30, so we'll begin. My name is Mark Salovitz. I'm the Division Chief of Ophthalmology, and it's my pleasure to introduce today's speaker, Dr. Cameron Ahmed. Dr. Ahmed joined our division in the summer of 2021 after having completed a fellowship in pediatric ophthalmology at Washington University in St. Louis. There, he also received training in pediatric refractive surgery, which is what he's going to be speaking to us about today. Dr. Ahmed has successfully built a pediatric refractive surgery practice at Phoenix Children's, and we are now one of 4 centers in the United States offering these services. Dr. Ahmed?
Good morning, everyone, and thank you to Dr. Salvitz for that introduction. I would like to just give a word of appreciation to Dr. Salvitz because without his support, this pediatric refractive surgery program would not have been possible. When I had finished fellowship in 2021, I had received training in pediatric refractive surgery, but I had not actually, started a practice because I was just coming out of fellowship. So his trusting me with this opportunity and having the foresight to give me this opportunity, it really means a lot, and it's helped this program to grow. And although I'm the one up here speaking, this pediatric refractive surgery program would not be possible without all of the hard work and efforts of my colleagues, our staff, everyone from the surgical staff to the clinic staff to the schedulers, to the administration staff. So everyone's really worked hard to develop really an amazing pediatric refractive surgery program here. But just by a quick raise of hands, how many of you have heard of pediatric refractive surgery before this talk today? Okay, so a few hands, but most people haven't heard of it. And that's not surprising because there's not a lot of centers in the country or even the world that do pediatric refractive surgery. But as Dr. Salvitz was saying, one of the types of refractive surgery that's done for children is called PRK. It's a laser surgery that reshapes the cornea, similar to LASIK. And there's only 4 centers in the country that offer that service to children. And then there's another type of refractive surgery called the ICL surgery, or the implantable collamer lens surgery. And there's only 2 centers in the country that offer that, and Phoenix Children's is one of them. So let's get right into it. I have no financial interest to disclose. So before we could talk about refractive surgery, we need to talk briefly about refraction. And if you all remember back to your high school physics, refraction is the bending of light as it travels from one medium to a different medium. And that bending of light happens because there's a change in the speed of light. And you can see that here, like in prisms. And in ophthalmology, this also happens when we look at how light enters the eye. So light is traveling as a cone of rays. And as it enters into the front of the eye, first the cornea, and then through the pupil and the lens of the eye, the cornea and the lens act as basically a lens that's changing the medium in which the light is traveling through, and that causes the light to bend. And for it to be in perfect focus, the light rays need to come together at a single point onto the retina. But in this case, in myopia, in nearsightedness, the light rays are coming into focus before hitting the retina. So myopia happens either because the length of the eye is too long, or there's too much refractive power in the front of the eye, either in the cornea or the lens. And so the light rays are not coming into focus on the retina, but rather before the retina. The exact opposite situation is hyperopia, in which, in this case, the eye is actually too short, or there's not enough refractive power in the front of the eye. So as the light rays enter in, they're coming into focus behind the retina instead of on the retina. And then the third type of refractive error is astigmatism. And astigmatism happens because there's different amounts of refractive power in different meridians of the eye. So like we were talking about, light travels as a cone of light. And if we look at this picture here, along this red meridian, the cornea has a steeper curvature. Along this green meridian, the cornea has a flatter curvature. So the light rays that are hitting the cornea along this red meridian, they're going to have greater focusing power and come into focus in front of the retina. Whereas light rays along the green meridian, they're having a correct amount of focusing power and they're coming into focus on the retina. So when all of the light rays are not coming into focus, all of the light rays in the cone are not coming into focus at one single point, that creates visual blur. So there's different ways that we can correct this refractive error of the eye. If you look at this picture here, the black line represents the eye without a lens in front of it, so the uncorrected situation. So the light rays are coming into focus in front of the retina, so this is a myopic eye. But if we put a biconcave lens, which diverges the light rays in front of the eye, then that lens is going to diverge those light rays and it becomes the red lines here. And then the corrected state is one in which the light rays are coming into focus on the retina. So these are the type of lenses that we would prescribe for someone who has myopia. And there's different ways that we can correct refractive error, and they occur at different planes within the eye. So the first would be spectacles, like in this situation here. The second would be contact lenses, if we were to place a contact lens onto the surface of the cornea to correct the refractive error. And then the third, fourth, and fifth are modalities of refractive surgery. So there's keratorefractive surgery, in which we can use an excimer laser to reshape the cornea. There's phakic intraocular lenses. Phakic because we're not removing the natural crystalline lens of the eye, but we're adding an additional artificial lens inside of the eye in order to correct that refractive error. And lastly, there's refractive lens exchange, in which we actually do remove the natural crystalline lens of the eye and replace it with an artificial lens. And there's different situations in which we use these different techniques, and I'll go over that more. So you all may have heard of refractive surgery such as LASIK. That's one of the most common surgeries performed in the world. And typically it's done in adults because, adults their eyes have finished growing. There's not much more change happening. Their refractions are usually stable. And so you can do refractive surgery in adults. And in adults, refractive surgery is done for spectacle independence. They're wearing glasses, they're wearing contact lenses, but they don't want to anymore. It's more of a choice that they don't want to, so they pursue refractive surgery. But in pediatric refractive surgery, the indications are quite different. So first, there has to be a significant refractive error. There has to be really a need for wearing glasses or wearing contact lenses. And the second thing that there must be in order to do pediatric refractive surgery is there must be some kind of difficulty with wearing spectacles or contact lenses. So when I say significant refractive error, in children, if significant refractive error is not corrected, it can lead to a condition called amblyopia. And amblyopia is a state in which the visual system of the brain fails to develop normally due to clear optical input coming from the eyes to the brain. And amblyopia can result in permanent vision loss for the life of the patient if that refractive error is not corrected at an early state in development. Additionally, refractive error in children can cause problems like strabismus, misalignment of the eyes, and that strabismus can also lead to amblyopia. Additionally, with high refractive errors, you can get very high power lens distortions. You can get prismatic effects from very high powered glasses, a narrowed field of view. You can get anisometropia, where there's a significantly large difference in the refractive error between the two eyes, like one eye might be a -10 and the other eye might not have any refractive error. And this can lead to a state that's called anisoconia, which is a significant difference in the size image between the two eyes, because very high-powered minus lenses cause a lot of minification, and very high-powered plus lenses cause magnification. So if there's significant difference in the two eyes, it can actually make it difficult for the brain to fuse the images between the two eyes. There can also be asthenopia with very high refractive errors, which is visual discomfort or strain or fatigue due to the refractive error correction. And the most common reasons that we see for pediatric patients having difficulty with wearing spectacles are neurobehavioral disorders, such as autism, Down syndrome, cerebral palsy, Angelman syndrome, and developmental delay. And many times, these patients have a sensory aversion to anything on their face or on their head. So even things like getting a haircut or wearing a hat can become difficult for them. And that includes wearing glasses. And sometimes we've seen, in our patients here at Phoenix Children's, they have such a high refractive error and they're living in a world of blur, but rather than wear glasses, because of their sensory aversion to something on their face, they would rather just live in the world of blur rather than wear their glasses. So refractive surgery can really, be a huge benefit to these patients because it just removes the need for glasses. And we've seen it many times over and over how life-changing it is for our patients. Other reasons for difficulty with wearing spectacles are poor head control. So patients who are wheelchair bound, when they wear their frames, the back of the frame hits the back of the wheelchair, they frequently get dislodged. So they have difficulty with wearing glasses. And additionally, craniofacial or ear abnormalities, which make it difficult to wear glasses. So this table here, this is a guideline from the American Academy of Ophthalmology for refractive correction in children. And this is not to show you, all the numbers, but really just to give you a sense that at different ages, there's a different threshold of refractive error at which we begin spectacle wear. So for example, here, if the patient's less than a year old, then if they have 5 or more diopters of myopia, then it's actually recommended even at less than a year of age to start wearing glasses. And that threshold decreases as patients get older. And the goal of this is to prevent amblyopia, because amblyopia is what will cause permanent vision loss in children. And this example illustrates for you what amblyopia is. So in this example here, the left eye is amblyopic, the right eye is not amblyopic. So let's say that this patient has a refractive error of -5 in the left eye and 0 refractive error in the right eye. Now, if this child grows up not wearing glasses, then the left eye is always going to be seeing blurry and the right eye is always going to be seeing clear. So the brain is going to develop a dominance for the right eye. And the neurons that subserve the right eye will develop normally. The neurons that subserve the left eye will eventually, through apoptosis and degeneration, fail to develop normally. And you can see that in functional neuroimaging in patients who have amblyopia in one eye. In this picture over here, these two patients, JF and OA, when they're fixating with their non-amblyopic eye, you can see the neurons in the occipital cortices are activated. But when they fixate with their amblyopic eye, there's no activity in the occipital cortex. So amblyopia is really a problem of failure of development of neurons in the brain. And that's what we're trying to prevent with pediatric refractive surgery. So there have been other studies that have shown the benefits of pediatric refractive surgery. There's improvements in communication, socialization, motor skills, and cognitive and language skills. And that makes sense because these patients are going from living in a world of blur to now being able to see things clearly. So Who are the patients who would not be candidates for pediatric refractive surgery? Well, for keratorefractive surgery, which is laser treatment of the cornea, if they have severe dry eye, exposure keratopathy, or ocular surface scarring, basically things that would prevent healing of the cornea after laser treatment, those would not be good candidates. Patients who have keratoectasia syndromes like keratoconus that cause thinning and weakening of the cornea would not be good candidates. Or patients with corneal dystrophies, congenital corneal opacities would not be good candidates. For the phakic intraocular lens, if they have uveitis or inflammation inside of their eyes, if they have glaucoma or high pressure inside of their eyes, if they have ectopia lentis, where the natural crystalline lens is dislocated, or a hypoplastic iris, those would not be candidates in addition to having cataracts. And finally, for refractive lens exchange, because this surgery does involve some manipulation of the eye in the vitreous chamber, if they have any pathology in the back of the eye, such as a vitreous collagenopathy or a retinal tear, that would not be the ideal candidate for this surgery. So in our preoperative evaluation for pediatric patients, all patients undergoing pediatric refractive surgery, they have at least one exam under anesthesia before the surgery. These patients also get a full ocular history and examination. So we ask about, what's the difficulty with wearing spectacles? Why is there a difficulty with wearing spectacles? Generally, we define difficulty with spectacle wear as wearing their prescribed spectacles less than 25% of waking hours. We assess their motility and ocular alignment to see if there's any strabismus. We get a cycloplegic refraction to measure, accurately through dilation and relaxing the ciliary body to measure what is their accurate refractive error of the eye. And then we also get ocular biometry, which are devices that we have to get very sophisticated and precise measurements of various dimensions of the eye that help us in surgical planning. So I'm very proud to say that here at Phoenix Children's, we have a state-of-the-art suite for ocular biometry. So it's actually upstairs in our Rosenberg Clinic. You can see here in this picture here, this is just one of the rooms. We have two rooms, but in this room, we have a corneal tomographer, we have a wavefront aberrometer, we have an IOL biometer, and we have specular microscopy. And that's a lot of fancy words, but basically we can measure like every part of the eye. It's very helpful, and not just planning for our refractive surgery patients, but even our cataract patients, our glaucoma patients. So one nice thing about the pediatric refractive surgery program here is it's actually really benefited other areas of our ophthalmic care as well. And obviously now these machines in the clinic, they require a patient to be able to sit at the machine, put their head there, fixate on the target in order for the machine to take the measurement. And not every patient can do that. So in our operating room for our exam under anesthesia, we have an equally sophisticated setup for measuring the various parameters of the eye as well. And just to show you some of the things that we measure, in this picture here, we're measuring corneal thickness. And that's important in keratorefractive surgery because when the laser reshapes the cornea, it's removing some of that corneal tissue. And as it removes that corneal tissue, we want at least a residual stromal bed thickness of 400 microns because long-term, that's going to prevent abnormal weakening and thinning of the cornea. Another parameter that we measure is called the aqueous depth, which is the distance from the back of the cornea to the front of the crystalline lens. And for phakic intraocular lens surgery, this distance needs to be at least 3 millimeters. Otherwise, implanting a phakic intraocular lens can lead to glaucoma or other problems. And then we also measure the distance that's called the white to white or the corneal horizontal diameter. And this distance needs to be at least 10.7 millimeters for a phakic intraocular lens. So I'm going to share with you three patient cases of patients that we've seen and treated here at Phoenix Children's. And each case is going to illustrate one of the refractive surgery modalities that we use. And these pictures are generated by artificial intelligence, and but they are representative of what the patients actually look like. So the first patient here, this is a 3-year-old male with autism spectrum disorder and global development delay. He had anisometropia, which is a significant difference in the refractive error between the two eyes. He also had some intermittent eye crossing, and he was completely non-compliant with spectacles or patching to treat amblyopia. He'd had a history of bilateral medial rectus recession, so eye muscle surgery to loosen the inner muscles of the eye. And you can see here his cycloplegic refraction. So in his right eye, he's a plus 1.5. In his left eye, he's a plus 3.5. And so the left eye, there was some amblyopia in that eye. There was some crossing of that eye. And if he would wear his glasses, it would actually treat his crossing and the amblyopia, but he wouldn't wear the glasses. And he had a normal anterior and posterior segment exam. So this patient was actually a good candidate for laser keratorefractive surgery, and the type of surgery more specifically is PRK, or photorefractive keratectomy. And the laser that we use, the excimer laser, it's actually a very large laser. It's a very large machine. And in operating rooms where it's short on space, we have to be very efficient with our setup here. So normally in adult patients, when they're treated with refractive surgery, it's just done in clinic with the patient awake and fixating on the laser. But for children, we have to do this under general anesthesia. So we have a bed that can swivel, and we swivel it into position 1. The anesthesia team induces the patient into anesthesia. Then we swivel to position 2. We do our exam under anesthesia, make sure everything looks good to proceed with the surgery. And then we swivel into position 3, and we do our laser treatment. So this video shows you how we do PRK surgery. So I have the patient's eye here. I'm treating the ocular surface with 20% ethanol and 2% lidocaine solution. And what that does is it loosens up the corneal epithelium. And then I'm going to mark the ablation zone here. So this is a 9mm diameter ring, and we're marking it with a gentian violet dye. And then we're going to use an electric rotary brush to remove the corneal epithelium. Once the epithelium is removed, then that exposes the underlying stroma, which is made out of collagen, and that's where the ablation occurs. Once yeah, so the corneal epithelium is removed right now, but it grows back after 6 days. Yeah, good question. So now you can see the laser here. You can see little bits of smoke coming off the cornea, and that's because the laser is actually ablating that collagen and it's getting removed. And now we're treating it with a mitomycin C solution that prevents fibroblast proliferation after the laser treatment and reduces corneal haze formation. And then we remove that. We put a bandage contact lens on the eye, and then the corneal epithelium can grow back under that bandage contact lens. And then the patients also put on a regimen of steroid and antibiotic eye drops. So 22 months post-operatively, the eye alignment had improved in our patient. There was no more crossing. The mother reported the patient was more playful, and there was no more fighting with him to wear his glasses. And you can see the cycloplegic refraction now is much more symmetric, a plus 0.5 in the right eye, plus 1 in the left eye. So in our second case here, this was a 13-year-old male with Angelman syndrome. He had developmental delay. He was nonverbal. He had horizontal jerk nystagmus of his eyes. And he had pathologic myopia. So myopia is considered pathologic when the refractive error is greater than -8. And you can see this patient's refractive error is a -19.5 in the right eye and a -16.5 in the left eye. And even with that refractive error, he still would not wear his glasses. He would just walk around only being able to see this far in front of his face. And he otherwise had a normal anterior and posterior segment exam. So this patient was a good candidate for phakic intraocular lens surgery. And there's two types of phakic intraocular lenses. The one over here in A is the Artisan lens. It's made by a company called Optech. And the design of this lens is it's an iris claw lens. So this lens actually clips onto the front of the iris, and you can see it here in the cross section of the eye. And then the second type of lens is called the ICL lens, or the implantable collamer lens. It's made out of a chemically treated collagen, so it's a very soft lens. And this lens actually goes in the posterior chamber, which is the area between the iris and the natural crystalline lens of the eye. So this surgery shows you implantation of the ICL in our patient. So we're making a superior corneal incision. We're injecting a substance called viscoelastic to make space into the eye. It's like a very viscous fluid that can kind of hold its shape inside of the eye. And we use that viscoelastic to tent up the iris so we can get into that space, that posterior chamber area. We then widen the corneal incision. And now we're injecting our ICL into the anterior chamber. And you can see it's a very flexible, soft lens. And then we're going to orient this lens because it's designed to be implanted horizontally inside of that posterior chamber. And we're careful not to touch the center of the lens to mess up the optics. And we've tucked the four corners of the lens into the posterior chamber. So we kind of tuck them behind the iris. And then we suture our incisions closed. Suturing incisions is usually not done in adults, but in kids we do it just because they might rub their eyes, or if something accidentally bumps their eyes, then that maintains the integrity of the incision. And then we're going to remove some of that viscoelastic because we don't want to leave all that viscoelastic in at the end of surgery, as it can actually cause the pressure of the eye to go high. In our surgical microscope here at Phoenix Children's, we have a technology called OCT, which is optical coherence tomography. Just pause it here. Optical coherence tomography. So what it does is it allows us during surgery to see a cross section of what's going on inside of the eye. So on the left here is what I can see through my viewing oculars on the microscope, but then I also get this overlay as well. And the OCT is showing us here these two lines. This is the ICL, and then this line here, this is the crystalline lens. And we can actually see the vault of the ICL over the crystalline lens. And that's important because if this vault is too shallow, then the ICL can rub on the crystalline lens and actually lead to cataract formation. And if that vault is too much, then the ICL can push the iris forward and cause angle closure glaucoma. So this is really nice technology that's allowed us to do this surgery more safely for our patient. So now we're just removing the viscoelastic. And we also inject a medicine to constrict the pupil and let the iris cover the ICL. And then we close our incision. We also inject some antibiotic into the anterior chamber at the end to prevent infection. And we also insert a little steroid insert into the punctum that dissolves over 30 days. And so this surgery truly can become dropless, meaning after surgery, patients don't have to do any drops because we've already given them their antibiotics and their steroids. And for many special needs patients, it's difficult to do eye drops. So it makes it easier for the family in the postoperative care. Additionally, in our microscope, we also have a digital overlay technology that we can take the data that we got in our preoperative biometry steps and load those into our microscope. And it can show us during surgery that biometry data. So here it's showing me what is the axis of astigmatism of this patient's eye. And when I implant this toric lens, which corrects for astigmatism, it needs to be lined up on that axis of astigmatism. And I can use that here with our microscope. So 3 months postoperatively, the father reported that the patient was much more interactive and interested in his surroundings. It had really been a life-changing surgery for him. You can see his refraction is much improved. He's a minus 3.5 in the right eye, minus 2.5 in the left eye. And since there was still some residual amounts of myopia, this patient actually went on, and I did PRK surgery for him to further correct that refractive error, and he's done well. So our last case, this is a 12-year-old male with pathologic myopia. He has pretty significant visual distortion and refractive amblyopia from the high-powered spectacles. So his best corrected vision, meaning with a perfect refraction, the best he can see is 20/30 in the right eye and 20/80 in the left eye. And the reason he cannot get to 20/20 is because his refractive error is so high that there's so much visual distortion from his glasses that he cannot clearly see that small 20/20 letter, even when he's wearing his glasses. So his refractive error in the right eye is a minus 21 and his left eye is a minus 22. And because of the high refractive error and the biometry data, this patient, we decided to do refractive lens exchange for him. So this is another example here of the digital overlay that we have. In this case, again, it's showing me the axis of astigmatism of his cornea. But instead of using a toric lens, I'm going to do an incision called a limbal relaxing incision. And what it is I'm making a 75% partial depth thickness in the cornea, and I'm going along the edge of the cornea here called the limbus. And what that does is it's relaxing the steepening of the cornea in that axis. And we can again use OCT to see the depth of our incision here. We're at 75% depth. So another way that, the technology we have here at Phoenix Children's really allows us to make these surgeries safer for our patient. So once we've relaxed that astigmatism, that's going to allow the patient to be more independent of glasses after surgery. So we make our main incision here again on the steep keratometric axis. We're injecting viscoelastic into the anterior chamber and also onto the surface of the cornea. And then what we're going to do is we're going to open the capsular bag. So the natural crystalline lens, it sits inside of a bag called the capsular bag. So inside of the bag is the lens material. So we're making an opening in the front of the capsular bag. And this is called the anterior capsular rhexis. And we have a digital overlay to tell us, what's the ideal size of that anterior capsular rhexis. So the diameter, the ideal size is 5 millimeters. So now I'm creating a 5 millimeter anterior capsular rhexis. And the video is a little sped up just to get through the surgery. So once we've opened our capsular bag, we're going to use balanced salt solution to separate the lens material from the capsular bag in a technique called hydrodissection. So we're going to inject this fluid, and you can see that fluid wave went across the back of the lens and separated it from the capsular bag. So now you can see that lens material is coming out. It's very soft in pediatric patients. We then enlarge our main incision. And we're going to use an irrigation aspiration instrument to aspirate that lens material. Once that lens material is removed, we can polish our capsular bag by removing any residual lens fibers or lens epithelial cells that can proliferate, later on and cause recurrence of any opacification of our lens. And now I'm injecting viscoelastic to stabilize the anterior chamber. And what I'm going to do now is I'm going to make a similar opening in the posterior capsular bag. So we're going to do what's called a posterior capsular rhexis. So I'm using a little needle here called a cystotome. to make a small opening in that posterior capsular bag. I'm now injecting viscoelastic in between the posterior capsular bag and the anterior vitreous face. And we're going to use our microforceps here to tear an opening in the posterior capsular bag. And we want it to be a similar size opening in the posterior capsular bag as well. And now we're going to inject our intraocular lens into that posterior chamber space. It's also called the iridociliary sulcus. It's the space between the iris and the capsular bag. So the lens has these little blue legs on it, which are called haptics. So the haptics are going to sit in the sulcus space. And then the center of the lens where the optical refraction occurs, that's called the optic. So we're going to make sure that our haptics are in the sulcus. So right now, this haptic on the top right of the screen is actually in front of the iris. You can still see it here. So we don't want it to be there. We want it to be in the sulcus there. So I'm going to position it there in the sulcus. And now once our haptics are in the sulcus, we're going to buttonhole our optic through the anterior capsular rhexis and then through the posterior capsular rhexis. And what this does, it makes the lens very stable. And both the posterior capsular rhexis and the anterior capsular rhexis are now in front of the optic. And so if there's any proliferation of any residual lens epithelial cells, it'll all occur in this anterior space here, and it won't go behind the lens. And that's a common problem in pediatric patients in that we can have opacification of the posterior aspect of the lens. But this is a nice technique that prevents that problem. So 7 months postoperatively, our patient is completing all tasks without spectacles. And you can see that his uncorrected visual acuity is now 20/30 in the right eye and 20/60 in the left eye. So his visual acuity after surgery without glasses is better than his visual acuity before surgery with glasses. And the reason for that is because we've gotten rid of the high power lens distortions from those high powered glasses. And then his cycloplegic refraction now is minus 2.25 in the right eye and minus 1 in the left eye. So in summary, pediatric refractive surgery addresses refractive errors and their associated comorbidities, such as amblyopia and strabismus in special needs children intolerant of spectacles or contact lenses. Pediatric refractive surgery involves modification of refractive errors at the corneal, anterior chamber, posterior chamber, and lens planes. And children with neurobehavioral disorders undergoing refractive surgery have improvements in visual acuity, communication, socialization, motor skills, adaptive behaviors, visual perception, and cognitive function. So with that, I'd like to thank you all for your attention. I'm happy to take any questions that anyone has. And I put on the final slide. I think, yeah, I have a bunch of extra slides. So let me go to that last slide for you. Okay. Yeah, so happy to take any questions.
Fascinating. I also learned that I personally have pathologic myopia, which in pathology, that's like not the worst one to have. But when I feel like when at the young age, the vision progressively gets worse, right, until like teenage years or so, then it stabilizes. So do you find that you may have to do repeat surgeries on these kids, or how does that, or do they at some point when they get older, maybe they'll tolerate the spectacles or some other method of correction?
Yeah, that's a great question. So similar to like, growth curves in children, we kind of can predict like if they follow this growth curve, they're going to grow at this rate. And by this age, they're going to be like this tall or this weight. So we kind of have that similar concept in ophthalmology for the growth of the eye, the refractive error change. And so say, for example, I'm doing pediatric refractive surgery on a 3-year-old. I have a target in mind that's different for a 3-year-old as compared to doing like a 10-year-old patient. I would aim for them to be a little bit more hyperopic in terms of their refractive error because there's going to be a myopic shift that develops as they grow older. So because I target that, then most kids follow the average, and so we don't have to repeat refractive surgery. But occasionally there are patients that they don't follow the average. But it's a minority of patients that have to get repeat refractive surgery.
Another quick
Yeah.
question, if you don't mind. It's impressive to hear that there's only 4 centers that are doing this in children's hospitals. What is the limiting factor in other children's hospitals? Is it professional expertise? Is it equipment?
Yeah, it's really a matter of expertise because you have to combine pediatric ophthalmology plus refractive surgery. And there's just not a lot of people that do that.
What's the youngest age that you that is common to do refractive surgery, and what's well, I guess talk a little bit about how common is it at different ages in the pediatric range?
Yeah, the youngest patient that I've done is 3 years old. So, in fellowship, the youngest patient we had done was 2 years old. But usually at those younger ages, such large refractive errors are not common. And as you saw in that table that I showed you of the recommendations by the AO, there is a greater amount of tolerance for higher refractive error at a younger age because, for example, they have like a greater ability to accommodate, which is changing the optical focusing power of their eyes. That decreases as children get older. So yeah, I would say it gets more common, kind of like maybe 5 to 10 years old, and then teenagers, those are more common.
And is myopia increasing in incidence, and do we really know what causes it, or?
Yeah, that's a good question. So there's a combination of genetic and environmental factors that is actually leading to basically a pandemic of myopic progression in the population. And some of it is genetic, we cannot control that right now, but environmental factors like lots of screen time or lots of up close work in children, that's been shown to increase myopia progression. So things like spending more time outdoors, looking at things farther away, those are things that to decrease progression of myopia. But actually, also one of the common things we see that is kind of unrecognized as a source of increasing refractive error in children is prematurity. So children who are born premature or who have a history of retinopathy prematurity, they have a higher incidence of refractive error. And as our technology for keeping these premature patients alive improves and we have more premature patients in the population, we're seeing also more refractive error as well. Thank you.